Okay, let's unpack this. Today, we're taking a deep dive into the fascinating and maybe often misunderstood world of cardiomyopathies. These are conditions that directly affect the heart muscle itself.
Exactly. They're not just obscure terms. They really get to the heart, quite literally, of how well the muscle can pump or fill or just
Yeah.
do its job.
Yeah.
And what's truly fascinating here is how incredibly diverse these conditions are. I mean, we're talking about everything from a heart that sort of stretches out and weakens to one that stiffens up,
Right.
or even, one that gets physically affected by like intense emotional stress.
Yeah.
But even with all these differences, there are common threads. And you might be surprised by some of the triggers and how they show up.
So, our mission in this deep dive is really to shortcut you to being well informed. We've gathered a lot of material, a comprehensive guide, and we want to pull out the key insights.
Making clear.
Exactly. So you walk away with not just facts, but a deeper feel for what happens when that vital heart muscle isn't working the way it should. Let's jump in.
So good.
Okay, first up, let's talk about dilated cardiomyopathy. This is often just called DCMP.
Right.
So if you imagine the heart's main pumping chambers, the ventricles, maybe like balloons, in DCMP they get enlarged, right? Stretched out.
That's a great analogy. They dilate, get bigger. But the problem is, as they stretch, they lose their elasticity, their ability to squeeze effectively.
Ah, okay. So they're bigger but weaker.
Precisely. That's what we call systolic dysfunction. The pumping action is impaired.
And that leads to this idea of a dilated, weak heart.
Exactly. And technically, we often see the ejection fraction, that's the measure of pumping power, drop below 40%.
40%. Okay.
Yeah. And this isn't just stretching. The muscle itself actually changes its structure. It's a process called myocardial remodeling.
Like it's adapting in a bad way.
Sort of. It gets bigger but loses its efficiency. And that stretching can also mess with the heart valves, the mitral and tricuspid valves, making them leaky.
And this is the common one, right? Accounts for most cases.
By far. Around 90% of all cardiomyopathies fall into this category. And we typically see it presenting between, say, 20 and 60 years old, a bit more common in men.
Okay, so what causes this? If it's so common, do we know the triggers?
Well, that's where it gets really interesting. For about half the cases,
Yeah.
we don't actually know the specific cause.
Half. Really?
Yeah, we call it idiopathic. It often has a genetic component, but it's essentially unexplained.
Wow.
But beyond that, there's a whole range of known causes. Viral infections are a big one.
Like from a cold.
Sometimes, yeah. Viruses like Coxsackie virus B, which can cause colds or stomach bugs, can lead to inflammation of the heart muscle myocarditis, which can then sometimes develop into DCMP. Even things like HIV or Chagas disease, Lyme disease.
Okay, so infections are key. What else?
There are infiltrative diseases where substances build up in the heart muscle, like hemochromatosis, that's iron overload, or sarcoidosis, autoimmune diseases too.
And I heard pregnancy can sometimes be a factor.
Yes, peripartum cardiomyopathy. It occurs late in pregnancy or in the months after delivery. It's relatively rare, but important.
Okay. Any lifestyle factors? Toxins?
Definitely. Chronic heavy alcohol use is a well-known cause. Cocaine, amphetamines too, even certain medications, particularly some chemotherapy drugs like doxorubicin or trastuzumab.
Wow, that's a lot of potential paths to the same problem.
It really is. Also, metabolic issues like thyroid disorders or even just a persistently fast heart rate can sometimes lead to it over time.
So how would someone, experience this? What are the symptoms like?
Typically, they look a lot like general heart failure symptoms. Since the left ventricle is struggling, you get fluid backing up into the lungs.
So shortness of breath.
Yeah, dyspnea on exertion is the most common. Feeling breathless when you do things. Also fatigue, just feeling tired, maybe finding it harder to exercise. Sometimes trouble breathing when lying flat, orthopnea, or waking up gasping for air.
That sounds pretty distressing.
It can be. And then as the right side of the heart starts to struggle too, you see fluid build up elsewhere.
Like swollen ankles.
Exactly. Peripheral edema, maybe seeing your neck veins distended, that's JVD. Sometimes a swollen liver or even GI symptoms.
Are there other, maybe less obvious signs?
Oh, yes. General fatigue, malaise, weakness, maybe loss of appetite, nausea. Some people report nocturia, having to pee a lot at night, or even memory impairment, sort of a brain fog.
And it can lead to more serious things too, right? Like clots or rhythm problem.
Absolutely. Thromboembolic events, arrhythmias like atrial fibrillation, and sadly, sudden cardiac death are all potential complications. But, and this is crucial, some people can have DCMP and feel completely fine. They might be asymptomatic for a long time.
So on a physical exam, what might a doctor pick up?
A key finding can be an S3 gallop. It's an extra heart sound.
Mm.
Sounds a bit like Kentucky. It represents blood rushing rapidly into that already dilated ventricle. You might also feel the point of maximal impulse, the PMI, shifted further to the left than usual because the heart's enlarged. You might hear murmurs if the valves are leaky, and signs of fluid overload like crackles in the lungs or that peripheral edema and JVD.
Got it. So how do you actually confirm the diagnosis? What tests are used?
The echocardiogram is really the workhorse here. It's non-invasive, uses ultrasound.
And it shows the weak pump and the big chambers.
Precisely. It clearly shows that systolic dysfunction, the low ejection fraction, often global hypokinesis, meaning the whole ventricle isn't squeezing well, and the dilated chambers, often with thin walls.
What about other tests? Chest x-ray, ECG.
A chest x-ray can show cardiomegaly, the enlarged heart, and signs of fluid in the lungs like congestion or pleural effusions. An ECG is often abnormal, but usually nonspecific. It might show a fast heart rate, maybe signs of previous damage, or arrhythmias like AFib.
You mentioned other potential causes. Do tests look for those?
Yes, absolutely. Lab tests are important. Checking thyroid function, HIV status, iron studies for hemochromatosis, maybe a toxicology screen if substance use is suspected. Genetic testing can be useful if a familial link is suspected. BNP levels, a blood test, can help diagnose heart failure and give prognostic information.
Okay. An MRI biopsy.
Cardiac MRI is excellent for getting detailed images of the heart muscle tissue. And coronary angiography, threading a catheter up to the heart, is often done to make sure blocked coronary arteries aren't the underlying cause, especially if someone doesn't have a known history of CAD.
And a biopsy, taking a piece of the muscle.
That's the definitive way to diagnose certain infiltrative diseases, but it's invasive and not done routinely, usually reserved for specific situations where we strongly suspect something like sarcoidosis or amyloidosis, and the diagnosis isn't clear otherwise.
So once you have the diagnosis, DCMP, what's the management plan? Is it basically standard heart failure treatment?
It largely is, yes. The cornerstone is guideline-directed medical therapy for heart failure with reduced ejection fraction. We're talking about medications that are proven to help people live longer.
Like ACE inhibitors, beta blockers.
Exactly. Angiotensin system blockers, ACE inhibitors or ARBs, beta blockers, and mineralocorticoid receptor antagonists like spironolactone or iobranon. Those are the key mortality-reducing drugs.
And for symptoms, the fluid.
Diuretics are essential for managing fluid overload and symptoms like shortness of breath and swelling. For some patients, especially in advanced stages, a combination of isosorbide dinitrate and hydralazine can be very helpful. Digoxin might be used sometimes too.
What about treating the underlying cause if you found one?
Oh, absolutely critical. If it's alcohol-induced, stopping alcohol is paramount. If it's related to a thyroid issue, treating that. Addressing the root cause whenever possible is key. And sometimes anticoagulation, blood thinners are needed if there's AFib, an artificial valve, or evidence of a blood clot in the heart.
Are there medications people with DCMP should avoid?
Yes, definitely. NSAIDs like ibuprofen or naproxen are generally a no-go. They can worsen heart failure, cause sodium retention, and actually reduce the effectiveness of diuretics and ACE inhibitors.
Okay, good to know. Anything else?
Most antiarrhythmic drugs need to be used with extreme caution or avoided, as many can actually worsen heart failure. Also, non-dihydropyridine calcium channel blockers, like diltiazem or verapamil, generally aren't recommended as they don't improve mortality and might even be harmful.
What about devices, pacemakers, defibrillators?
Yes. For patients with a significantly reduced ejection fraction, say below 30–35%, an implantable cardioverter defibrillator, or AICD, is often recommended to protect against life-threatening arrhythmias and sudden cardiac death.
And some patients get special pacemakers.
Right, cardiac resynchronization therapy, or CRT. That's a biventricular pacemaker used for patients with a weak heart and evidence that their ventricles aren't beating in sync, usually indicated by a wide QRS complex on the ECG. It can improve symptoms and function.
And for the really severe cases.
When medical therapy isn't enough, then advanced options like cardiac transplantation or a left ventricular assist device, an LVED or mechanical heart pump become considerations.
Okay, that's a comprehensive look at DCMP. Now, you mentioned earlier that myocarditis, that inflammation, can cause DCMP sometimes.
That's right. It's a really important connection. Myocarditis is essentially an inflammation of the heart muscle itself, the myocardium.
And it's often caused by...
Often idiopathic, meaning we don't find a specific cause in about half the cases. But infections are the most common known trigger, especially viruses.
The same ones you mentioned for DCMP.
Yes, exactly.
Yeah.
Enteroviruses like Coxsackie and Echovirus, parvovirus B19, adenovirus, herpes viruses, influenza, hepatitis C, HIV, and yes, SARS-CoV-2 has also been clearly linked.
So the body's immune response to the virus ends up attacking the heart?
That's the prevailing theory, yes. An inflammatory response that damages the heart muscle.
Yeah.
But it's not just viruses. Bacterial infections like Lyme disease or diphtheria, parasitic infections like Chagas disease,
Wow.
and also non-infectious causes. Autoimmune diseases like lupus or rheumatoid arthritis. Certain medications, clozapine is a notable one, methyl-dopa, some antibiotics, even toxins like cocaine or heavy alcohol use.
Who typically gets myocarditis?
It's most commonly seen in young, previously healthy adults, often people in their 20s, 30s, 40s.
And what does it feel like? Is it always dramatic?
It's incredibly variable. That's what makes it tricky. Many patients have a viral prodrome, first a week or two of flu-like symptoms, fever, muscle aches, feeling unwell, maybe vomiting or diarrhea.
Okay, like getting over the flu.
Right. Then, maybe a couple of weeks to even a few months later, they develop new or worsening heart failure symptoms, the shortness of breath, fatigue, swelling. That's probably the most common presentation in adults.
But sometimes it looks different.
Yes, sometimes it presents very much like an acute coronary syndrome, like a heart attack,
Yeah.
acute chest pain, maybe a week or so after an infection, ECG changes suggesting ischemia, elevated troponin levels.
But the arteries are clear.
Exactly. Coronary angiography shows no significant blockages. It can be really confusing initially. Sometimes it presents more like pericarditis, with inflammation of the sac around the heart, causing typical chest pain and ECG changes.
And sometimes it's really severe.
Unfortunately, yes. It can present with life-threatening arrhythmias or cardiogenic shock, where the heart suddenly can't pump enough blood. This often happens about 2 weeks after that initial viral illness. In children, it might look different, maybe grunting respirations or visible effort in breathing.
So diagnosis sounds challenging. You suspect it if someone youngish, without typical risk factors, develops heart failure or chest pain after being sick.
That's the key clinical suspicion trigger, yes. New heart failure, chest pain, or arrhythmia, plus positive cardiac biomarkers like troponin without traditional coronary risk factors, often following a recent viral illness.
What about tests?
Chest x-ray might show an enlarged heart. ECG is usually abnormal, but nonspecific. Maybe sinus tachycardia, sometimes patterns that look like pericarditis.
Yeah.
Labs show elevated troponin, maybe inflammatory markers like ESR or CRP. Viral titers aren't usually that helpful acutely.
And the echo.
The echocardiogram is crucial. It typically shows ventricular systolic dysfunction, a weakened pump, reduced ejection fraction, often global hypokinesis, similar to DCMP in some ways, but often more acute.
Is there a definitive test?
The gold standard is histopathologic evidence from an endomyocardial biopsy actually seeing the inflammation in the heart muscle tissue.
But you said that's rarely done.
Right. It's invasive, carries risks, and often doesn't change the immediate management unless the case is a usually severe, rapidly worsening, or if we suspect specific types like giant cell myocarditis. So it's reserved for specific, complex situations.
Okay. So how is myocarditis managed then, if it's often viral?
A lot of it is supportive care, managing symptoms, ensuring adequate oxygen, managing fluid status. Importantly, limiting physical activity during the acute phase is recommended.
Does it get better on its own sometimes?
Many mild cases do improve spontaneously, yes. But follow-up is important, often with serial echocardiograms to track recovery. For patients with reduced ejection fraction, we use the standard heart failure medications, the ACE inhibitors, ARBs, beta blockers, possibly diuretics, and mineralocorticoid antagonists to support the heart function.
And things to avoid. You mentioned NSAIDs earlier for DCMP.
Yes, critically important here too. NSAIDs should be avoided, especially acutely, as they might actually impede healing and worsen inflammation in myocarditis. Also, avoiding cardiotoxic medications, heavy alcohol use, and strenuous exercise during recovery is key. Digoxin is also generally avoided acutely as it might increase inflammation.
All right. Let's move to one that captures the public imagination a bit more, often called broken heart syndrome. Stress cardiomyopathy, or Takotsubo.
Ah, yes, Takotsubo. It's a fascinating condition. It's essentially a transient, meaning temporary regional systolic dysfunction of the left ventricle.
So a temporary weakening.
Exactly. It often mimics a heart attack very closely. But crucially, there's no significant obstructive coronary artery disease, no blocked artery or plaque rupture causing it. It's considered a form of non-ischemic cardiomyopathy.
And the broken heart name comes from the trigger, right? Emotional stress.
That's often the case, yes. It predominantly affects postmenopausal women, and it's frequently triggered by significant physical or, more famously, emotional stress.
Like what kind of stress?
It could be the death of a relative, receiving a catastrophic medical diagnosis, intense fear, even sometimes surprisingly positive stressful events. A sudden, intense surge of emotion or physical strain.
What's the mechanism? How does stress physically do that to the heart?
It's thought to be multifactorial, not fully understood yet. But a leading theory involves a massive surge of catecholamine stress hormones like adrenaline.
Ah, the fight or flight response gone wrong.
Kind of. That catecholamine surge might directly injure the heart muscle cells, or cause dysfunction in the tiny microvessels of the heart, or even trigger coronary artery spasm. This leads to that distinctive pattern.
The octopus trap shape.
Exactly, the transient apical ballooning. The apex, the bottom tip of the left ventricle, balloons out and doesn't contract well, while the base of the ventricle might squeeze even harder. It looks like a Japanese octopus trap, which is takotsubo in Japanese.
And the symptoms? Just like a heart attack?
Very much so. Substernal chest pain, shortness of breath, sometimes syncope or fainting, often occurs right after that intense emotional or physical trigger. Patients might also show signs of acute heart failure.
So how do you tell it apart from a real heart attack? You have to rule that out first, right?
Absolutely critical. It's essentially a diagnosis of exclusion because it looks identical to an acute coronary syndrome, ACS. Initially, ECG often shows ST elevation, especially in the anterior leads, mimicking a STEMI, and cardiac biomarkers like troponin are elevated.
So everyone gets treated for ACS initially?
Yes, aspirin, maybe nitroglycerin, beta blockers, heparin, statins, the standard ACS protocol. The key diagnostic step is coronary angiography.
To look for blockages.
Right. And in Takotsubo, the angiography shows the absence of acute plaque rupture or significant obstructive coronary artery disease that would explain the extent of the heart muscle dysfunction.
And then the echo confirms the shape.
Yes, the echocardiogram shows that characteristic transient regional wall motion abnormality, specifically that apical ballooning of the left ventricle. Those are the key Mayo criteria for diagnosis. ACS symptoms, ECG changes, positive biomarkers, but no obstructive CAD on angio, and that typical wall motion abnormality on echo.
Since it's transient, what's the management after diagnosis?
Once ACS is ruled out and Takotsubo is confirmed, management is largely conservative and supportive. Often beta blockers and ACE inhibitors are continued for maybe 3 to 6 months. Serial imaging, usually echo, is done to monitor the recovery of left ventricular function.
And it usually recovers fully.
In most cases, yes. The ventricular function typically returns to normal within weeks to a few months. It's a remarkable, usually temporary condition.
Okay, fascinating. Now, let's pivot to the remaining key types. These seem quite different again. Restrictive cardiomyopathy, RCM, and hypertrophic cardiomyopathy, HCM, stiff hearts and outflow obstructions.
Right. These involve very different structural issues than the dilated or stress-induced types.
Yeah.
Let's start with restrictive cardiomyopathy, RCM.
This is about stiffness, right? Not weakness.
Exactly. RCM is primarily a disease of diastolic dysfunction. The ventricles, the main pumping chambers, become rigid and stiff. They are typically non-dilated, so they're not stretched out like in DCMP.
So they can squeeze okay, but can't relax and fill properly.
Precisely. That stiffness impedes diastolic filling, the relaxation phase. The heart struggles to accept blood coming back into it.
What makes the heart muscle stiff like that?
It's usually caused by infiltrative diseases conditions where abnormal substances deposit within the heart muscle itself. Think of things ending in aleosis. Amyloidosis is the most common cause in the U.S. Abnormal proteins, either transthyretin or light chains, build up in the heart. This can affect older adults, but also people as young as 40. Sarcoidosis is another key one, an inflammatory condition forming granulomas. Suspect that, especially in younger patients, may be presenting with unexplained fainting or heart block, particularly common in Black women.
Any others?
Hemochromatosis, iron overload, can do it. Also fibrosis, maybe after radiation therapy or in conditions like scleroderma. Basically, stuff builds up in the heart muscle, makes it stiff, reduces its compliance, and makes it hard for the ventricles to fill.
And because filling is impaired, the upper chambers get overloaded.
Exactly. The atria have to work harder to push blood into those stiff ventricles, so they often become significantly dilated over time.
What are the symptoms of RCM like?
Because the filling pressures build up, symptoms of right-sided heart failure are often more prominent than left-sided ones.
So more swelling, neck veins.
Yes. Significant peripheral edema, jugular venous distension, JVD, hepatomegaly, enlarged liver, maybe ascites, fluid in the abdomen, GI symptoms. Left-sided symptoms like shortness of breath on exertion, orthopnea, fatigue, cough certainly occur too, but that systemic congestion often stands out.
Does amyloidosis have specific signs?
It can, yes. Things like syncope, protein in the urine, proteinuria, peripheral neuropathy, numbness tingling, carpal tunnel syndrome, sometimes characteristic bruising around the eyes, periorbital purpura, or a thickened tongue.
What would you find on physical exam?
You'd see those signs of right-sided failure, the edema, JVD, a positive hepatojugular reflux. Kussmaul's sign is characteristic where the JVP paradoxically increases with inspiration, and you're more likely to hear an S4 heart sound, reflecting that atrial kick into a stiff ventricle, rather than the S3 common in DCMP.
Okay. How is RCM diagnosed?
Chest X-ray might show normal ventricular size but enlarged atria and signs of pulmonary congestion. ECG often shows low-voltage QRS complexes despite a thick-appearing muscle on imaging, which is a clue essentially for amyloidosis. Arrhythmias are common. BNP levels tend to be quite elevated, which can help distinguish it from constrictive pericarditis, where BNP is often low.
And echo again.
Echo is the primary diagnostic imaging tool. It shows that classic pattern. One diastolic dysfunction with a restrictive filling pattern, systolic function might be preserved, especially early on. 2, marked biatrial enlargement. And 3, non-dilated ventricles with walls that are normal thickness or maybe slightly thickened, but look very stiff or sparkling in amyloidosis.
Definitive diagnosis, biopsy again.
Yes, endomyocardial biopsy is the definitive test to identify the specific infiltrative process, amyloid, sarcoid, iron deposits.
You mentioned distinguishing it from constrictive pericarditis. They sound similar.
They can present very similarly, both causing diastolic dysfunction and right-sided failure symptoms. But key differences. RCM is a problem of the muscle, usually has that S4 or maybe S3 later, high BNP, biatrial enlargement on echo. Constrictive pericarditis is a problem of the pericardium, the sac around the heart, might have a pericardial knock sound, maybe pericardial calcification on imaging, and typically a low BNP.
What's the management for RCM? Can you treat the stiffness?
Unfortunately, there's no specific treatment that reverses the stiffness itself for most causes. Management focuses heavily on treating the underlying disorder.
Like chelation for hemochromatosis, steroids for sarcoidosis.
Exactly. Phlebotomy for hemochromatosis, specific therapies for different types of amyloidosis, immunosuppression for sarcoidosis. Heart transplant is really the only definitive treatment for the heart failure itself in refractory cases. Symptom management involves cautious use of diuretics. Medications like beta blockers or certain calcium channel blockers might help control heart rate or symptoms, but don't fix the core problem.
Okay, a tough one. Now let's switch to the last major type. Hypertrophic cardiomyopathy, HCM. This is the one often associated with athletes and sudden death, right?
That's correct. HCM is infamous for being a leading cause of sudden cardiac death in young people, including athletes. And it has a strong genetic component. About half of cases are familial, usually inherited in an autosomal dominant pattern due to mutations in sarcomere proteins, the building blocks of heart muscle.
So instead of dilated or stiff, the muscle here is too thick.
Yes. It's characterized by left ventricular hypertrophy, thickening of the heart muscle that isn't just due to high blood pressure or other known causes. It's often asymmetric, meaning one part thickens more than others, especially the septum, the wall between the ventricles.
And this thickening causes problems. How?
2 main ways. First, like RCM, the thickened muscle makes the ventricle stiff, leading to diastolic dysfunction, impaired relaxation, and filling. But the really unique and often dangerous feature of HCM is subaortic outflow obstruction.
Obstruction getting blood out of the heart.
Exactly. That thickened septum can bulge into the path where blood exits the left ventricle towards the aorta. And often, the mitral valve leaflet gets pulled towards the septum during something called systolic anterior motion, or SAM, further narrowing that outflow tract.
Okay, creating a bottleneck. And this raises an important question. What makes this obstruction worse?
Great question. It dynamically worsens with anything that increases the heart's contractility, like exercise, or drugs like digoxin, or anything that decreases the volume in the left ventricle, like dehydration, or maneuvers like standing up quickly or straining, Valsalva.
So less blood in the chamber or harder squeeze makes the obstruction worse.
Precisely. Think of it like the walls closing in more easily when the room is less full or when they're pushed harder.
What are the symptoms for someone with HCM? Or are they often asymptomatic?
Many patients are asymptomatic, diagnosed incidentally or through family screening. When symptoms occur, they often relate to that left ventricular outflow tract, LVOT, obstruction. Dyspnea on exertion, shortness of breath with activity is the most common symptom, seen in about 90% of symptomatic patients. Fatigue, chest pain, angina, and syncope fainting or presyncope near fainting, especially related to exertion, are also key LVOT symptoms.
And the really scary part, sudden death.
Yes. Here's where it gets really critical for the listener. Sudden cardiac death is a major concern, especially in adolescents or pre-adolescents, often occurring during or just after extreme exertion. It's usually due to ventricular arrhythmias triggered by the abnormal muscle and outflow issues. A family history of sudden cardiac death is a very significant risk factor.
What about the physical exam for HCM? What clues might you find?
You might hear a loud fourth heart sound, S4, due to the atrium contracting forcefully against that stiff hypertrophied ventricle. Sometimes a pulsus bispherians, a double-peak pulse can be felt.
And the murmur, is it distinctive?
Yes, there's a characteristic systolic murmur. It's typically a harsh crescendo-decrescendo murmur, best heard between the apex and the lower left sternal border. A key feature is that it usually does not radiate significantly to the carotid arteries in the neck, which helps distinguish it from aortic stenosis.
Okay, and this murmur famously changes intensity with maneuvers, right? That's the fascinating part.
It is. This is a classic diagnostic clue. The murmur intensity increases, gets louder, with maneuvers that decrease preload, less blood returning to the heart, like standing up from squatting or performing the Valsalva maneuver, or with things that decrease afterload, like amyl nitrate.
So less blood in the heart makes the murmur louder.
Right, because the outflow tract gets relatively narrower. Conversely, the murmur intensity decreases, gets softer with maneuvers that increase preload, like squatting, passive leg raise, or that increase afterload, like hand grip.
More blood or resistance makes it quieter.
Exactly, because it helps to stent open that outflow tract a bit. These dynamic changes are really helpful in diagnosing HCM at the bedside.
So how is HCM definitively diagnosed?
The ECG is often abnormal and quite sensitive, frequently showing signs of left ventricular hypertrophy, LVH, sometimes deep abnormal Q waves that can mimic a prior heart attack. But echocardiography is the key diagnostic test.
What does the echo show?
It confirms the diagnosis by showing that asymmetric ventricular wall thickness, particularly the septum, often 15 millimeters or more. It can visualize the SAM of the mitral valve, measure the outflow tract gradient, the pressure that clicks across the obstruction, show the small LV chamber size, and assess the diastolic dysfunction. Genetic testing is also important, both for the patient and for screening first-degree relatives.
What's the management strategy for HCM?
For symptomatic patients, pharmacological therapy is first line, aimed at reducing symptoms by decreasing heart rate and contractility and improving filling. We use negative inotropic agents.
So drugs that weaken the heartbeat slightly.
Essentially, yes, or slow it down to allow better filling. Beta blockers are generally preferred first line. Non-dihydropyridine calcium channel blockers like verapamil are an alternative. Sometimes disporamide is added.
What if medications aren't enough?
For patients with persistent severe symptoms and significant LVOT obstruction despite meds, surgical options exist. Septal myectomy is an open-heart surgery where a surgeon literally removes or shaves down part of the thickened septum to relieve the obstruction. It's very effective, especially for younger patients.
Is there a less invasive option?
Yes, alcohol septal ablation. It's a catheter-PEEP procedure where a tiny amount of alcohol is injected into a small artery, feeding the thickened septal area, causing a controlled small heart attack to thin that muscle area. It's an alternative, particularly for older patients or those who aren't good surgical candidates.
And given the sudden death risk, defibrillators again.
Absolutely. An implantable cardioverter defibrillator, AICD, is recommended for primary prevention in patients deemed high risk based on factors like massive hypertrophy, family history of sudden death, unexplained syncope, or certain arrhythmias, and it's used for secondary prevention in anyone who survived a cardiac arrest.
What are the crucial cautions for people living with HCM? What should they avoid?
This is vital. Patients should avoid dehydration, as that can worsen the obstruction. They should also avoid extreme exertion and highly strenuous competitive exercise. Volume depletion needs to be avoided.
What about medications to avoid?
Digoxin should generally be used cautiously, if at all, as increasing contractility can worsen the obstruction. And medications that significantly decrease left ventricular preload or systemic vascular resistance, things like potent vasodilators, including nitrates, most diuretics, ACE inhibitors, ARBs, should generally be avoided or used with extreme caution as they can paradoxically worsen the LVOT obstruction and symptoms.
Wow. Okay. So we've taken a real deep dive into this diverse world of cardiomyopathies, from the dilated weak heart to the stress-induced broken heart, and then these stiff or overly thick muscles in RCM and HCM. It's truly amazing how the heart muscle can be affected in so many fundamentally different ways.
It really is.
Yeah.
And if we connect this back to the bigger picture, I think understanding these distinct types, knowing their different causes, how they present symptomatically, the nuances in diagnosis, it really empowers you. Whether you're just curious or maybe trying to understand a condition affecting someone you know.
Yeah, it clarifies things.
It helps clarify why certain symptoms really demand medical attention and why specific treatments are chosen for one type versus another. It helps make sense of a really complex area of heart health.
So, what does this all mean for you listening? Maybe consider this. The heart, our most vital organ. It's incredibly resilient in many ways, but also surprisingly vulnerable, as we've just heard. This deep dive into cardiomyopathies really highlights that intricate balance needed for it to function properly. It makes you wonder, what other overlooked aspects of health might have such profound implications hidden beneath seemingly common symptoms?